And now it's time for our very rich panel discussion because we have many questions from all over the world. And the first question is for Olivier. And I believe every one of the faculty can answer that. And everyone's asking about not just Sandra from Colombia. Everyone is asking about how to choose the best filler for the periorbital rejuvenation. What are the specific characteristics that you would look for, and how would you choose your HA filler?
The most important when you have to choose the filler, the good filler for the region, and it's to have experience with this filler, experience with very superficial injection, with the tolerance of the patient. I don't add any chlorure of sodium. I don't mix anything. I always use hyaluronic acid pure. I don't do any mixing. That's an important point. The cross-linking is important, but the most important characteristic is the hygroscopic adaptation and the hygroscopic power of the HA. I mean, if your HA will attract water in this region, it will be very, very difficult, and you will have the Tyndall effect, okay? Because as you know, you will inject onto the bone, so the resorption will be very, very difficult.
Okay, thank you. Marina, what do you think about that?
I don't think that there is a clear characteristics of hyaluronic acid to be used in this area. I think it should be some soft product, and it's a little bit of a poetic definition, but it should be soft HA, because the hardness of the product depends on the HA concentration, the cross-linkage level, the cross-linkage technology. So the outcome is a soft product, because this area, we need to fit the rheology of the product with the rheology of the soft tissue, and soft tissue here it's soft. Now, regarding the water absorption, I think we cannot ever guess it. It's very unpredictable, and it's very much patient related. So my rule is to undercorrect. 80% correction is a perfect level of correction when we are talking both infraorbital but also supraorbital. When I'm correcting a deformity, I'm never trying to bring to full correction. And again, I always tell my patient, listen, it can absorb water more than we predict. So be ready if it's swollen, if something looks wrong, please come back. It is very easily treatable. I think this is the most important message that we have to deliver to our patients. Otherwise, they will go to somebody else, and then we'll get some unhappy patients.
Okay. Hervé Raspaldou, what do you think about that? And would you use a high G prime filler like Voluma in low doses in this area?
Which area?
The periorbital.
Periorbital. So
yes.
I would use a high G prime on the midface to lift the concavity of the midface, but certainly not on the tear trough, and not diluted with any lidocaine or other liquid, because products are done by companies who has done a lot of scientific research, and I'm really against changing the rheology, mixing with a lot of stuff. So to answer the question, Voluma in low dosage, I don't know what it means. I don't dilute Voluma, I don't dilute the Stylage XXL. I use a product as it is. There is a product for volumizing the midface, and there is other product like Stylage S or other product with a less concentration.
Okay.
I think the question
for me, oh sorry, Sorry, Marina.
It's about the amount. I don't think that it's some adding something. I think that the Dr. Muslaski from Argentina asking about using voluma in small amounts in the periorbital region. For me, the answer is yes. I think that voluma is quite soft. So in small amounts, it can be safely used in periorbital region.
I don't use because yeah, I don't use voluma in this region in periorbital, including in the lower eyelids. But as I said in my talk, and Marina agreed, the most important is to be prudent and safe when you inject. Tell your patient the treatment will be in 3 times. 2 or 3 times. This is not a complication. You do it a low dose, very hypocorrection. You check patient 2 weeks or 3 weeks after you add a little bit, depending of the reaction of your patient, and you can check it at the 3rd time. And in my practice, these 3 consultations, these 3 visits, I include in the full treatment. They all make part of the complete treatment, step by step.
Okay, I agree to that. I know this is a controversial point. Some colleagues like Marina can do some low volumes of voluma or high G prime filler for the periorbital region or the tear trough injection, but I personally don't prefer to do that, but it still works for some of us. So now for the next one, and it's for Marina as well. In the US, the hyaluronidase comes in 150 units per 1 ml. So how many units shall we use for retrovulvar injection?
I think it's very, very complicated. There is no single answer because the first answer whether when we're talking retrovulvar, it's to treat vision loss. And as I mentioned, there is no clear answer to this question, whether it's treatable at all. I think that in this case, if you have a patient that just lost, complaining on losing the vision, as you injecting her, you should inject higher dosage of hyaluronidase. So I would inject 150 units. Again, I think it's something like maybe 750 units with our European hyaluronidases. So it's not a very extremely high dosage. And hyaluronidase is very safe. I'm not afraid of hyaluronidase over-treating with hyaluronidase. The problem when they inject retrovulvary, it's actually the volume that you are injecting. You need to inject quite a high volume to hope that it will reach the HA embolus on time and quickly. On the other hand, you cannot overfill the retrovulvar space. So it's not per 1 ml. In this case, I will probably put it in 2.5 ml or 3 ml and try to inject it. Again, it's against the recommendation of American Society of Dermatologic Surgery, which considers retrovulvar injection as a procedure to be performed by a specialist, which means ophthalmologist.
Okay, thank you for this answer. Dr. Raspaldo, which product is currently CE marked and indicated for eyebrow injections?
I don't know.
Okay. Anybody has an answer for that?
I think that in 2023 or 4, when each product will have to be indicated for a specific area, we will probably know. Currently, there is no product, as far as I know, which is specifically indicated for orbital area. On the other hand, there is no, it's not forbidden to inject HA in the periorbital, any HA in the periorbital area.
One important thing is that HA or other fillers will move after injection, months and years after injection, and you can find silicone in tear-through. Your patient said, "I've never been injected in that region, but I had injection in eyebrows, for example." And it can be the same with HA. You can have filler with very high density in the eyebrow, and you can find later in tear-through. with edema and the Tyndall effect without any injection in this region. Marina showed us a case of this.
I agree. Yeah, completely agree. I think that most of the patients who are coming with Tyndall effect years after the injections are not injected in T-trap, they're injected in mid-face. So after repetitive smiling and moving the mid-face muscles, some of the product is pushed up to T-trap area, and this is the explanation for having Tyndall effect without being injected in the T-trap. So if the patient comes to you and she's having swelling, puffiness, Tyndall in the T-trap, and she rejects the possibility of ever being injected in T-trap area, in most of the cases, she has been injected in mid-face, and the treatment is hyaluronidase.
Okay, and now for the sake of time, we have one final question for Olivier about what technique of injection do you use and which brand do you recommend us? There is no specific one. Everybody's asking about the type, but kindly share your experience.
I will talk about injection in the tear through. My technique is using a needle. It's a direct deep injection with bone contact. I mean, I'm doing about 3 to 5 points just around the arcus marginalis, onto the arcus marginalis contact with 2 fingers. My left finger is controlling exactly the position of the eye, and I'm very precise with this injection. Javier shown us that the localization of vessels in this region, and I don't have any important edema, hematomas, but I don't use cannulas in this region, only needles to be deep in bone contact.
Can I say the two sentences?
Yeah, sure.
I think when we're talking infraorbital injection, I differentiate between T-trap, which is the indentation, to infraorbital pathology, which is a combination also of infraorbital fat herniation. So for the real T-trap deformity, younger patient, good skin quality, I think the deep injection with cannula can work. For infraorbital pathology, it never works. So I also use needles, but not as Olivier is doing it. I actually inject very superficially. And I think that with the minimal amount of product, like 0.2, 0.3 ml, you can provide a very significant correction of infraorbital pathology. So it's not all the patients are the same. They need to understand exactly what we are treating.
Yes, assessment definitely will give better insight in which technique to use. We have many techniques that can be followed, but proper assessment is the one that leads us to get the best results. And yes, we shall go step by step, as Olivier mentioned. And I'd like to thank you all for your participation, your time, and your dedication for this webinar. And I'm sure that hundreds of live attendees, the last number I've received from the tech, that we have almost 800 live viewers, which is really great today. I hope everyone has enjoyed it. Thank you very much for your time.
Thank you, the speakers. This has been amazing. There's a super heated debate on the chat. Just to let you know, there's been one-to-one interactions, off-label, on-label indications, which product, how many millimeters. So it's you have answered many of their questions. Thank you to all the experts and our chair, Dr. Sadek, for answering the audience. And but just to let you know as well, all of you speaking on the chat, if you click on each other's names, you can add each other to your own connection and continue speaking through private messages. So if you want to continue sharing your opinions and advice or discussing as you are on the chat, just add each other on the IMCAS Academy and go ahead and connect and continue your talk. So the next webinar, if you have enjoyed this webinar, we have the next one coming up in June 1st. It will be about neck facelift and how to choose between the open or closed procedure. So this will be granted by APIX, and the scientific partner will be EADV, if I'm sure. Yes, okay. So the next class that we also want to incentivize you to join, there is exactly 800 of you connected live viewers. Dr. Sadik, you were correct. So all of you watching, there is a new anatomy and aesthetic treatment class that Dr. Benjamin Asher and Professor Kotofana are currently preparing for you, July 15th to 17th. You can, this class is actually a very interactive class. It's virtual. There will be live dissections, live demonstrations, and this class, the special thing is that you can actually interact one-to-one with the experts as they're doing their procedure. Stop them at any time in the dissection or in the injection and ask them questions so you can perfect your own practice. So if you want to be part of this class, you can register on thinking.fr. So this is a collaboration with IMCAS. So again, www.thinking.fr. You can register for this class happening on July 15th to 17th. And next as well, we have coming up in July 10th, 11, our IMCAS Asia conference, which will be happening. There will be a room in Shanghai. You are lucky enough to be over there and head to the Congress itself. There will be 2 rooms in Shanghai. You can be there on site, or you can be online, of course, join the virtual sessions. Everything will be, there will be 4 channels. Everything will be transmitted as well, dissections, the usual of IMCAS, so you can go ahead and join. So thank you once again to all the speakers. Thank you to our AV director, Regis, for making it possible as well. He's always there behind the screen making all the technical happen. And see you for the next webinar, all of you. So have a good evening or morning or good day. Bye-bye.